Hello, my name is Dr. John Longfree. I'm an occupational medicine physician out of the United States. My specialty is occupational and environmental medicine, and that deals with worker injuries, chemical exposures, biological exposures, and anything that a worker could be injured by. My background includes some work in the bioterrorism field. We were involved in the anthrax scare. We were also involved in the Ebola remediation project of a few years ago, and amongst many other similar type of projects. So today I'd like to answer your questions. This is a Q&A session on COVID-19, coronavirus 19, also known as the SARS-CoV-19 virus that we're seeing in the news these days. I've been provided with many questions, so let's go ahead and get started. Question number one is, when an employee tests positive for the COVID-19, who should we isolate and why? So let's suppose you have someone who is positive. Anyone that has spent more than about 10 to 15 minutes within 6 feet of that person will be put into what's called quarantine. So they will go out of work, they will go home, stay with their families, and stay away from the workplace for approximately 14 days. It is that period in which, if you were going to become sick, you would typically become sick within that 14 days. If you don't become sick, then we believe you were not, in fact, you are not in fact sick, and you can come back. That is why. It is to prevent you from becoming infected and spreading that to other people before you realize you're infected or sick. And we'll talk about that more in a bit. Question number two is, if a family member of an employee tests positive, who should we isolate and why? The person that should be isolated would be our employee, who is working or living closely with that person's spouse, husband, wife, whomever, and for the same reasons, we just don't want someone to spread this should they become ill. Number three, is it true that the most contagious period is 2 days before developing symptoms? That is not true. We're not quite sure exactly when people become contagious before they have symptoms. It could be as soon as 2 or 3 days prior to developing full-blown symptoms of coronavirus. And those symptoms would be, of course, cough, fever, those sort of flu-like symptoms. So 2 to 3 days is possibly a contagious period. We're not quite sure. The data is still coming in on that. But typically you're going to be more contagious once you're showing much in the way of symptoms. So if you are coughing a lot, blowing your nose a lot, you will be more infectious than someone who is, or contagious than someone who is not blowing their nose, someone who's not coughing, someone who's not spewing out respiratory droplets from their face, I guess, their nose and mouth and so forth. So that would answer that question. Question number four, do you think we have to disinfect surfaces of a confirmed case that has been identified 2 days before? Yes, you should. Yeah, go ahead and use an approved disinfectant, typically either an alcohol-based disinfectant, a bleach-based disinfectant, or a peroxide-based disinfectant. Those are the ones that primarily are used. Once we disinfect the surface, how long will a surface remain clean? The surface will remain clean until it's recontaminated. That's simple. There's really nothing else to say on that. Question number five, what is the cycle of the virus? Okay, this is a deep question. We go into this in more detail in another webinar that we've done. But just briefly, the virus is like a ball with little suction cups all over it. It goes into the lung. It attaches to a specific protein inside the lung. through that protein. It injects its genetic material called messenger RNA. The messenger RNA hijacks your body's cellular machinery that your body uses to replicate DNA and make protein, steals that, and basically makes itself in millions and millions of copies. Those copies sort of leak out of the cell back into the lung and may infect other cells nearby. In the meantime, your body is mounting a response to this. Your immune system tries to fight back and does fight back, and most of the time fights back very successfully. In older people that are sick or have some pre-existing health conditions, typically, very old people, their immune system may not be powerful enough to fight back. At the end of the day, what really causes the demise of or death in these very old, very sick patients is really a simple plumbing problem. Your body makes so much phlegm and so much in the way of just gook and snot and everything that the lungs get clogged with that, and your lungs cannot exchange oxygen and carbon dioxide. That's their job, is to bring oxygen in and to get rid of carbon dioxide. You may remember that from grade school. So part of the problem is the human body, and so that's why we have been experimenting not only with just antiviral medicines, but with steroids as well. Steroids would blunt that immune response. In other words, it would hopefully shut off the overreaction of your body. That's very common to many diseases. In many diseases, we have to shut off the immune system. In any allergy, it's like that. In any autoimmune disease, it's very common for the immune system to overreact to a perceived threat. It's probably a little more than you wanted to hear, but let's see. Since the contact or infection can infect other people to being symptomatic to being cured, okay, that was sort of a follow-on. Once you clear the virus, once your immune system can beat back this virus, again, we don't have really strong medicines that we know for sure can inactivate this virus in your body or kill it. We don't really use the word kill with viruses, we say inactivate. But if your immune system can overcome that infection, the chances of you being reinfected by the same virus and developing symptoms are very little. By that point, you have antibodies that can fight the virus. And that's similar to many other viruses like influenza, which changes every year, all the other little coronaviruses that we're exposed to all the time. Anyway, there's nothing new about coronaviruses. They've been with us for millennia, thousands of years, maybe longer. Question number 6, do you have any data about asymptomatic people? We talked about that a little bit ago. Yes and no. There's some theoretical discussions, and there's some data to suggest that people have what's called a high viral load. That means you have much virus in the phlegm and in the snot, despite not being sick. In some cases, there was a German study, they found that some of the people that had no symptoms had higher viral loads in their snot than people who became sick. That's not unusual. It's not unusual to be asymptomatic and clear the infection. I read one study yesterday that said 2/3 of people that contract the flu illness never develop symptoms. We think the numbers for, say, Lyme disease are even much higher, above 90%, as one source reported. So in other words, 90% of the time, people contract Lyme disease and they don't even know they have it, and they clear the infection and they go about their lives just fine. So that's not unusual. An asymptomatic situation is not unusual. Perhaps, maybe, this particular virus is more contagious in that asymptomatic period than most other viruses that we see. We're still learning, okay? So we'll keep, more to follow on that as the days and weeks progress and we learn more. Number 7, how long does the virus last on surfaces, objects, elevator, car, and so forth? Well, based on prior studies of similar coronaviruses, the longest that we've seen is about 9 days. In some cases in the air, it can be a matter of a few hours. On cardboard, it was a few hours. On copper surfaces, and it was a few hours. On stainless steel and plastics, can be a few days. The conditions determine how long the virus will remain active and contagious. As far as one of the big questions is, can I touch a contaminated surface and become ill? Presumably, but we're not 100% sure on how that happens, or whether or not that happens with regularity. And so keep that in mind, that we're still learning. The most common way we think that people become infected is to, in fact, inhale a respiratory droplet coughed by someone who is sick. So that was question number 7. Question number 8. When should we use PPE and how effective are the masks protecting our employees? A common question I get. You always got to remember that the surgeon, when he or she goes into the operating room, is wearing the mask to protect the patient, not himself or herself. That's the rule with those. When we work in the hospital and we go take care of tuberculosis patients, or these COVID-19 patients in the respiratory wards or the respiratory ICU, we gown up, we put on our mask, we wear gloves and so forth while we're in the room treating the patient. Once we leave the room and are in the hallway outside the room, we remove all of that. So typically, I'm not wearing a mask right now. I'm not wearing a mask out in public. I don't think you need to wear a mask out in public. However, I do understand that there's a reassurance factor there. A typical surgical mask won't increase your risk of contracting the disease. We know that. And we're not talking about respirators here, so that's a totally different discussion. Just plain Jane, bread and butter surgical masks are all we're talking about right now. Again, if you want to wear one, I don't have any problem with that. And then what type of PPE PPE again is personal protective equipment, so gloves, masks, and so forth. Should we use to enter the high-risk facility like a hospital or in an outbreak area? You're going to be working in smaller areas that perhaps have been touched by ill people, perhaps, let's say a hospital. So certainly if you're going to be in the high-risk areas around the pulmonary ICUs and so forth, you're welcome to wear a mask. That's fine. Typically, you're better served by simply wiping down the items that you're working with, the buttons, wiping those down first with an approved disinfectant. You can inactivate many of these viruses within a minute or two of contact with one of those disinfectants. As far as gloves, it's okay. You're not going to hurt anything. What I would probably rather do than wearing sweaty gloves all day long is to just wipe down the surfaces and clean them. And again, do not touch your face or your eyes or pick your nose, because that would be how you could transplant the virus right into your body. So and remember, people that wear gloves still touch their nose, still touch their face, and so forth. So the gloves are not necessarily a be-all and end-all protection there. You really have to just prevent it from getting into your nose, eyes, and mouth. That's at the end of the day, that's what we're worried about. Question number 10, let's see. How frequently should we replace the masks? Well, I mean, you can, so to speak, reuse a mask. I mean, I've done it. That's fine. You can even rub a little hand sanitizer in there as long as you let it dry out, and that will clean it out. Should we use masks in the office? Probably not. That's probably overkill to use a mask in the office. Do you know any self-testing kits available in the market? Not for this. The machines used to analyze for messenger RNA and viruses, they're like $1 million. They're called PCR machines. They're quite expensive. So no, there's not any machine yet that's on the market. If yes, do you consider them reliable? I'll skip over that because there is no kits. In fact, it's pretty hard to get kits. Even doctors are having trouble getting the kits. Can you tell us a bit more about the high-risk populations, elderly people, and so for people with chronic diseases and pregnant people? That's an interesting question. So let's just start. The average age of people that are succumbing to this illness is like almost 80 years old. It is literally higher than the average age, average lifespan of most countries that are affected. So I'll say that another way. Most of the people that end up dying from this have already exceeded the average age of the people in their country. So that's a key point. These people are frail, elderly. They have lots of health issues to begin with, and therefore they're at risk for not just this, but for just a cold, influenza, or even any kind of minor illness could also kill them. And the numbers that we're seeing are fortunately not tremendously high relative to influenza and a variety of other illnesses that are probably more dangerous to them, or in terms of numbers are more deadly to them if you just look at the numbers, like things like flu and many other illnesses and exposures like car crashes and a variety of other things. Even MRSA. MRSA, I think, kills in the United States something like over 20,000 people every year. So keep that in mind as you put all of this into perspective. Let's see, pregnant women. Before we get into pregnant women, one more thing on the people with chronic diseases. Primarily lung and heart diseases, diabetes. Diabetes affects your immune system response. So those three categories are particularly high risk, and if you're in one of those categories, be a little bit extra cautious, especially if you're older. Pregnant women, we're not seeing a spike in pregnant women problems with this. Pregnant women are generally young and otherwise healthy, and remember, once the baby has formed its internal organs, its solid organs, and its limbs, the baby inside the mother is very, very tough, very strong. People forget that in the second and third trimester, the babies are very, very resilient and very, very resistant to insults, both chemical and otherwise. We're not seeing an issue. We're not seeing a cluster of cases or an increased number of cases with pregnant women. Question number 13. Today, there are a lot of sources of information, not always consistent data. In your opinion, which reliable source should we use to guide our employees? Well, that's a good question. Much of the mass media news that's being presented, remember, they're printing everything. And they're not necessarily waiting for a study to be replicated first. In fact, in science, we have a bit of a crisis right now in that something like 70% of science studies, including medical studies, are not reproducible. So if you take the recipe for the experiment, move it to another university with some other researchers, they get different results in 70% of the time. So take everything you hear and see in the media with a grain of salt. Don't necessarily believe it all. There's a lot of things that are coming out that will be found inaccurate or invalid as time goes forward. That's normal. There's nothing unusual about that. We see that all the time. So when I hear something presented in the news that coffee is good for you, and then coffee's bad for you, and then coffee's good for you again, or tea or whatever it is, then you always want to take those with a grain of salt. Sometimes we don't know for many decades exactly what is good for you and what isn't. It's just the truth, sorry. Then we have, reliable sources. I've been using the CDC and a few other sources, some European sources. But in general, the CDC is pretty good. The CDC, fortunately, has been willing to show their humility in this situation, in that they have said in many places on their website that, look, we don't really know this or that. We don't know exactly how this is transmitted off of surfaces like we talked about earlier, and which medicines will work. What exactly is the definition of close contact with an infected person? All those things are open to debate at this point, and we may only learn after all of this has blown over, which we're going to talk about in a little bit. So number 14, when a person starts having symptoms, which medication should be used before going to the hospital? Well, I mean, typically you're going to see people treat themselves with Tylenol prior to coming to the hospital. There was a French politician tweeted that ibuprofen will increase your risk. There's no strong evidence for that. That's a theoretical risk that hasn't been borne out in any kind of study. So we don't think that's really an issue yet, although I do understand the rationale, the logic behind that French politician's tweet. I get it. It kind of makes sense, but there's no indication of that, and ibuprofen is so widely used, we're not seeing big problems there. So I wouldn't necessarily hold back on that. Are there any medications that alleviate the symptoms? This illness is treated. I mean, yes and no. We're learning. I don't want to report yet. There's some report that a malarial drug called chloroquine combined with maybe some antivirals might work. There's some studies that show that some flu antiviral medicines for influenza might work. Of course, just like Tamiflu, also known as oseltamivir, many of you have probably taken that. Many of you probably know that your doctor probably told you, if you don't take this starting in the first 24 hours of symptoms, then it doesn't work. We're sort of seeing that kind of picture emerge, where with these flu-like, with these antiviral medicines designed for influenza, you have to start them early. Don't misunderstand me. Currently, there's nothing sort of approved or obviously appropriate for this situation. We just don't know exactly. There's some initial reports that have come out, and then some have come out again that have discounted or said that it doesn't work. So we're still learning. The primary medicine is really not a medicine, but it's your immune system. Your immune system will beat this back. If you're otherwise healthy, it will take care of this. You will get better. Again, the primary people affected almost entirely are very, very elderly people that have exceeded the lifespan of their fellow countrymen. We're seeing very little deaths in young people and children and middle-aged people. You really have to be above about 60 and have some big health problems for this to be a true threat to your own personal existence. Okay, so question number 15. Does the COVID-19 illness present with mild symptom also affect the patient's lung? Yes and no. There have been some studies of asymptomatic people. They've done chest x-rays and seen a little bit of stuff on the lung, but not enough where the person would have any symptoms. So we don't really know. There are very small numbers of cases. And then in the severe cases where you have, what we call shock lung or acute respiratory distress syndrome, ARDS, yes, I mean, there can be some long-term effects to the lung, as there would be with anybody that has any kind of ARDS. Like if you aspirate pond water and get ARDS, you would have the same issue. So nothing unusual or particular to COVID-19 in that regard. But for the most part, the vast majority of people will completely recover without any long-term problems related to their lungs. Now, smoking, there's a question of whether smoking, I mean, in general, there's been no studies that address that question in particular, but that's just too fine of a question to ask for scientists to go at it in this stage of the illness. or stage of the pandemic. But what we're seeing is that yes, there are some long-term issues that can occur in people, and smoking is something that would put you at a little higher risk because it's sort of a diagnosis. It could, especially, it might depend on how much you smoke and how many years and all that stuff. So number 16, how long do experts estimate the outbreak to last? That's a very good question. We don't really know. It kind of depends upon the response of all the countries to kind of keep everything at bay. I would, my guess at the current date, mid-March 2020. My estimate is probably another 3 months at most. So maybe sort of early summer to midsummer. I think this will all be, I hope, ancient history, but we really don't know. So I'll hedge a little bit on that. So that's, there were some other questions that came out after this that I'll try to answer. One was a porta potty question. So these are those portable toilets, the big green or blue toilets that you go inside. In general, we don't see people get disease anyway. I think it's because that is such a, an unsavory place to be, that you get in there, you don't touch anything, you get out of there as quickly as possible. You're spending minimal time in there. People are not getting in there and reading books and so forth. So we generally don't see people. There's never, to my knowledge, been like an influenza outbreak or another coronavirus type outbreak from using a porta potty. Obviously, or a measles outbreak or anything like that. What I would do is, use your common sense. Don't touch anything that you can avoid touching while you're in there. Wipe things down, bring your hand sanitizer. Make sure that when you use hand sanitizer that you waft your hands dry. It's really not until your hands get dry again that the bacteria and viral load is controlled. So keep that in mind. The other question was, well, how do you avoid becoming a carrier if you're bouncing between, let's say, airports and hospitals and nursing homes and schools? Wash your hands. Wash your hands frequently. Wash your hands before you enter and make sure your hands are dry. Again, you can use alcohol-based hand sanitizer. That's why you see surgeons, after they wash their hands before surgery, do this to dry them out and then put their hands in the gloves. That sort of thing. Avoid touching your mouth and nose and eyes and that sort of thing while you're making the transition, and you should be okay. Again, the inanimate object, gross contamination, if someone really vomits on you, that's a different story. Clean your clothes, wash yourself, and so forth. These are all things that nurses and doctors know how to do instinctively. But just be careful out there. So that concludes this call. Thank you for attending the COVID-19 Q&A session. Everybody be safe out there. Don't panic. You're going to be okay. This should all blow over eventually. I promise it will. But until then, everybody have patience and be safe. We'll see you.